And we're really excited to have a good friend of ours on the show today, Bryon Williams, an expert in price transparency, in the nuances of price transparency when it comes to medical practices. Bryon helps medical practices as a healthcare consultant in looking at their contracts and helping them negotiate and helping them know what's in the market. And he's been very deep in this data, but also he understands the nuances of the actual contracts and has been helping his customers kind of navigate this new world that we live in with price transparency. So I want to welcome Bryon to the show. Thanks so much, Bryon, for joining us.
Yeah, thank you for having me.
Awesome. So Bryon, like your role now, so I know you've got a background in being a practice manager. So you, I guess from that perspective, can deeply understand the challenges and goals of medical practices, and now kind of from there to consulting and helping them. Can you kind of talk about your journey and how you got started?
Yeah, I strangely got my start. I was going to college and I got a call during like the holiday break that a physician needed some help in their practice. They had to let a couple people go. And like, I just need help for 2 weeks. And I went in there, and not to give away like too much of my age, but it was a time when things were transitioning from paper charts to electronic medical records. And that was like a brand new thing that everybody was slowly, it wasn't mandated yet, but slowly converting over to. And so in that 2 weeks, I actually converted the physician to electronic records, scanned all the paper charts, had them ready to go like within that 2 weeks. And so that doctor was like, "Hey, do you want a job?" And so that's just kind of how I started, was starting to embrace technology. Like that's always kind of been my thing, was like, what can level us up to the next thing. And so I was fortunate enough to work with a physician. His name was Dr. Brent Clyde, that empowered me to do that. So anytime there's a new technology, something that we could implement, text messaging, things like that for our clients, he let me embrace that. So for 18 years, worked with him as like the main leader of the group. And, after 18 years, it kind of became a natural path for me to go on to consulting and kind of expand that to other groups, other medical practices. And that's when I joined the firm I work with now, Eide Bailly, was after 18 years, to then help other small practices kind of implement those changes, embrace technology to kind of help them improve with the different things that are out there.
Very cool. How'd you hear about Eide Bailly? I mean, they're big. They're they're like a top 20 accounting firm in the US, aren't they?
Yeah, they are in the top 20 accounting firm, consulting firm. I happened to be like on a trip going to California, and I was just on LinkedIn, and somebody recommended it to me because they said, "Hey, like, I actually think it was my boss that, because we were trying to sort out our next path. He was moving to a different state. I was trying to sort out where I wanted to go. He's like, this is exactly what you should be doing with it." So I applied for it, got a phone call, I think that same day. Like I had a voice message after I'd landed from the plane, and just kind of set things up that way. I, like most people, pronounced Eide Bailly different when I started on there. It's like it's a different name on there, but yeah, that's kind of how I got started with them.
Very cool. That all computes to me. Just getting to know you and work with you. You're a pleasure to work with, and you're so passionate about helping people and helping these organizations, and you're so passionate about data and technology and putting that to work in the real world. I could totally see somebody saying like, "Hey, this is." Recommending that even your boss, as your original boss, as you all were kind of transitioning. And that's really neat. I didn't realize that you had done so many different aspects of what a medical practice needs from the very beginning, just digitization of their operations, basically.
If I could scan stuff, I would do that as like a stress relief, like, like just scanning charts. Like, I remember just doing it, like, oh, let's organize the files now. Like,
I remember my first job. I was a document imaging assistant, but I can't remember my exact title, but it was my job to scan and
Yeah.
digitize documentation and paperwork at Emory. So yeah,
It,
at the time I had
it,
no idea why we were doing it. I'm like, why are we doing this? This is horrible as we're scanning. That's wonderful. Oh,
well,
that's
and
funny.
the amount of scanners, like I still own one of the scanners from before, just to scan a bulk scan of everything in there for like family members. Like I'll do it. But
Right.
just going from that, like I lived in a world where people brought in their X-rays, like they printed them off on film, hold them up to the light, transition
Yeah.
over to CDs. Eventually, people put them on CDs, load them on the computer, put those into the charts. Now everything's advanced so far, but yeah,
Man. And then I mean, seeing all of that from EHRs and EMRs to now we're in this interesting space where we've got one of the largest healthcare data sets never released. And kind of the other interesting thing about it is where most people think of really large healthcare data sets as genomics data sets or EHR data sets, patient level data. This is contract data, which has been really interesting. And I tell you what, even now, right? This original law was in 2019, and then enforcement in 2022, and then the data, getting much better from 2022 until now, and then some new kind of doubling down on the rules as of a couple of days ago on the 25th of February, as we record this on the 28th. It's come a long way, but I still hear so much um, negativity and hesitancy around putting this data to work, which is why I'm so excited for you to be on the show today, because you're the absolute opposite of that. You were tip of the spear, jumping in and helping people and seeing a lot of success. And I think more people need to hear about that, especially for medical practices who, as we know, are being squeezed by large organizations, by PE firms. And we know when PE firms buy these organizations, the cost of healthcare goes up, because obviously we're removing competition from the market. So I guess all of that happening, when did you first hear about price transparency and kind of start using it for good? And what has that journey been like for you?
yeah. I think kind of like everybody else, we heard about it when it was first announced, but then there's the different phases in it. And I think a lot of times it just kind of got shuffled in with the noise because there's the different levels of transparency, like the hospital publishing their files.
Right.
And so I think that was kind of the first push. And so then medical practices are like, well, that doesn't apply or whatever. So then once they start hearing the next phases, it just got sent to the background because it didn't apply a year ago, so it doesn't apply now. But kind of staying on top of it, of like, okay, what's the next iteration of it? And then really, it was probably been about 2.5 years that really started looking into it because I tried myself downloading them and making sense of them, and no, like I'll stick to scanning in paper charts, like kind of thing. Like organizing that type of file is out of my league, and so we just started searching out, who can we use to help us help our clients and those medical practices. Like working with a consulting firm, we always referred to this data set as the golden ticket that didn't used to exist. We're like, if we had this, we could do so many different things with this information. And a lot of times our clients would come to us like, oh, well, your firm is like number one in healthcare. Like you work with all these community access hospitals, rural healthcare, medical clinics. And I think they just thought that, like on the sly, we could give them the information from our other clients, which we can't. We couldn't do. That's confidential. Like, but we're like, yeah, as soon as it comes out, as soon as it's like publicly available, there's these laws. Once it's ready, then we can start partnering up and like show you this information. So now, like clinics just aren't sure of the legality because you used to get a contract from an insurance company and it says you cannot share your rates with other competitors on what you're getting paid for this. And so I was on a phone call last week and they're like, this is legal. Like, we're like, yeah, we're not sharing anything confidential that we as consulting firm have. This is quote unquote publicly available information. We partner with a third party, so that we're not like going into our clients' systems and getting this information to
Right.
show it to you. And so had to send them the links to CMS, show them, this is this is the law, this is okay, this is where we get it from, and this is how we get it. And then, it's a lightning bolt, because that it's not just payer contracts, it's strategy, it's like all the different things that you can apply this data towards that you just couldn't do before, and at a faster pace.
That's really I don't know how Jerry feels when he hears something like that, but for me it's, I don't know if humbling's the right word, but it's like we have a lot more work to do to make sure people know that this is available. Because I'm also, while I want to be shocked by that response that you had only a week ago in 2025, after this has been being enforced for 3 years and change, I also run into that. Um, I I've been at conferences where I'm showing data, and I have even a large insurance carrier came by and was like, "How did you get our numbers?" And I had to go to their website and be like, "Look, you're posting." So yeah, so that's still where we are, and that's interesting, right? The variation in knowledge is about as broad as the variation in prices for healthcare. It's you got people that to your point, have heard it but said, "Oh, that doesn't apply to me," and it kind of ignored stage 2, 3, so on and so forth. You have people that haven't heard about it at all, and then you have people like yourselves that have been using it for a long time now, since it's been out, and have seen the evolution of it, and I'm sure have matured your methodologies and strategies for how to use it. You mentioned um, this not even being able to enforce with or not just only being able to help with contracts, but informing strategy. What do you mean by that? What kind of strategies can this help with?
Yeah. So if you're a group and you're like, we talk to them like, what's your 5-year strategy? What's your 10-year strategy? Like, we want to help our smaller practices grow and do other things. So if you're like an orthopedic surgeon, you're looking to put in like an X-ray or a radiology wing or department in your group. What are you going to get reimbursed for that on your current contracts? Like, getting that set up. So a lot of times you can feed in those rates into and say, can we afford it? Should we do it? Kind of thing. What are we going to get reimbursed if we go this route for it? Or what are other people getting reimbursed for these services? If you're entering someplace new, you want to build an ambulatory surgery center, what are they getting reimbursed for the rates that for the services that we do? So it can inform decision making on the unknown. Like, a lot of people feel like they can just look back at their existing data, see what am I getting paid from this payer for this um, office visit code. That's in their existing somewhat, but the unknowns are usually not in there. A lot of payers, when you ask for a fee schedule, won't give you the entire fee schedule, their entire reimbursement rates. They might just give you the codes that you bill for, or that you have billed for,
Interesting.
and you have to dig deeper to ask for the different rates for it.
What is
The
it? What
beauty
is
on
this?
this,
Oh, go ahead. Go ahead.
just with the data too, like, you can look at, like, on the modifier level, like if you're just looking at doing the technical part or the professional level, like in your strategy, like inching towards it, those sorts of things, you can see those rates for it.
That's interesting. I didn't think about that. So being able to, you're able to have a much more focused, granular, whatever the word may be, strategy regarding services, not only that you do perform today, but that you don't, but could, and kind of model out a what if analysis of what could that do. Can we, to your point, can we afford this? Maybe we know there's a demand. Our patients need it. Our community needs it. What will this look like? Can we afford this? And what are other people doing?
Right. And you can easily take that to the bank for a loan and show that information. Like, this is information, invest in this
Wow.
prospect on there. Some other ways are for when groups want to have conversations together, you're trying to recruit a physician in there. If you have good rates and like part of their compensation is based off of revenue that you generate or your compensation from certain plans, you can show them we have pretty decent rates in our market. So we can afford to pay you your salary. Like we've seen that from our clients, having that conversation to help recruit physicians to come to their group, saying we have this compared to this larger group or to this hospital group on there.
That's really interesting. Okay. So very nuanced use cases. It's not just the contract negotiation. You're now we're getting into strategy for new services. Now we're getting into um, recruiting, and so it's really helping these smaller practices just kind of strengthen their foundations, especially with this highly competitive market.
Yeah, when you think about smaller practices, like they don't have the robust analytics team like larger organizations have. They don't have like necessarily strategy meetings. That's where me and my firm kind of come in. Like hire us for this one-off project, and let us look at it. Let us help direct your strategy. Because even in contract negotiations, we may not get what competitor A is getting for their rates, but that opens the door for us to ask the payer, like, how do we get to that level? Like, what do we need to do to get our rates increased? What do you see in them that we need to do? Do we need to open up a different ancillary service to like fully serve our patients and improve our patient care experience for that, and come up with a 2-year plan for the next route that we go to the payer of saying, okay, we did this, this, and this. Like I hope that payer transparency like alludes to more transparency in everything. Like this
Yeah.
is how you're getting an increase. Like, like everybody, when they ask for a raise from their employer, they like to show this is what we did. This is how we got there. Like I've justified my check marks to get this increase, taking that to the payers, and then they can help us set a plan with our clients on getting the higher rates the next go round.
Right. What are the conversations like with the carriers, with the insurance carriers, with the payers, um, when you're like, I had this thought or question when you were talking about asking for a fee schedule and them not sending you the entire fee schedule. I guess, what is that conversation like? What is the back and forth like? What are their timelines? Who are you reaching out to there? And I'm guessing, are they very open and helpful with this, or are they? I imagine there might be some resistance, but I'm not sure.
Well, yeah, they're like any other organization. They have their red tape and their bureaucracy that it goes through.
Mm,
So generally, we're working with the clinic's provider representative. That's like our first step. If they have one. Some payers have like a certain email you have to email it to. We tell our clients, this is going to be a months long process, not a days, not a weeks. It'll take 2 to 3 weeks to get a response from your provider rep. And sometimes they'll send you that fee schedule in a PDF form, even though in our email we'll say we want it in an Excel. Like it's just, and
wow.
we know to tell our clients ahead of time. They're going to send you a PDF. They're just going to send you your top 100 codes or whatever. This is the follow up email to send another 2 weeks. So like being able to get that information quickly speeds up the cost for our clients, because time is money. Like 6 weeks is a long time to wait for the tools we need just to start the job. We had one client that, this was before we had the information that we were asking the payer for the fee schedule. They sent it to us, and we always like double check with like their actual claims data just to make sure that it's within realm on it. And we're like, this is way off. Like, this just doesn't make sense. And so we ended up having to email the provider rep back, and they're like, oops, we sent you the wrong one. And so that was like a 4 week like back and forth that
No.
we had to start over again because the provider rep accidentally sent the wrong fee schedule for it. So
Wow.
human
Okay.
error again. But yeah, those are the sorts of things that you just have to go back and forth with on the representatives, where like, getting this, download the information, get the snapshot, let's run with it and kind of look at what it is.
Now, in the price transparency data, you can generate a fee schedule, have you seen that they're similar? Are they I guess with if the carrier sends you the correct fee schedule, does does it match what they're posting? What's different about it? Or is there some nuance where it's not quite apples to apples? Like what's that been like?
In the data that we download from the machine readable file, it's more specific than the
Oh,
fee schedules that we get. So, we can download it by payer plan. Normally, like we get a fee schedule and this is the rate. And we normally would get like all of the modifiers that you could possibly have. Normally you get, the global fee, a professional and technical fee. That's what everybody is probably used to getting from the provider rep, because it would completely blow out an Excel spreadsheet to get the
right.
entire like fee schedule. Like I do like the feature to keep it what we're used to, like filtering it down to professional, technical, and the global. Like that's the phase that we need to be in right now
Mhm.
for it to look at it, because otherwise then we're asking for a large data set from the clients that they may or may not be able to generate all the different modifier combinations as well. But yeah, being able to look at by plan, by state, um, even by NPI number, group NPI number, if there's different nuances into it, is a huge help. That's done in a day versus 6 weeks of waiting for an Excel fee schedule that we then have to go and verify. When we start talking with you on verifying, I don't want to give you any trauma remembering what I was like trying to verify everything on it, because
That's
we
fine.
have doing so many previous negotiations. We had contract with us handful of clients, hey, can we test your current fee schedules against this data for future use? Your information was 100% correct with the fee schedules that the payers gave us after we renegotiated that for them. Obviously, there's nuances with place of service and stuff like that and modifiers,
Sure.
but yeah, I haven't come across one that wasn't correct.
Wow.
I mean, it's
That's really
obviously different for payers that have multiple plans that pay different rates, because it's difficult to go back to a client's EHR and tie this POS to their POS in their system, because maybe their front
ah,
desk person just put it as a blanket insurance company and it could have been any one of these seven rates. But I just had a client that I sent a snippet to verify just to make sure he felt good about it, and they're like, my range was smaller and higher than their range, but I was able to show in your data, like there's these two other plans. And they're like, oh yeah, there's nobody in our area that has these two plans on the min and max. I'm like, well, that's why mine are off. And I could
mhm.
show exactly their min was the next plan in line and their max was the next one on top of it. And so it worked out great.
That's great to hear. It's and you know how we've engaged and we engage with all of our customers. We do everything in our power to make sure that you have the data exactly as it is at the granularity. Not We make sure we get every single file so you're not missing hidden files, which means we can't go through that plan. That plan level will sometimes, actually, a lot of times, have you miss huge files with billions of, hundreds of millions, billions
Right.
of rows of data in it that are for legitimate rates with legitimate providers. Um, and then we then kind of back associate all of those files with plans, and then have to go do a lot of plan cleanup. But the plan is a really important when thinking about the nuance, um, of this data, which is why we never filter anything out and allow our customers to slice and dice the plans. But it's also important to remember, um, while we're doing all of that, we're still communicating what the insurance carrier has verified and attested is accurate and posted. And it's been a long journey, and they've never done this before, and there's system limitations on their side. And so that's why we've always been very engaging and open, and yeah, let's compare it to the fee schedule. We want to know if we hope it matches to the penny, but we need to know if it doesn't. And um and for people who started this in 2022, they ran into a lot of situations where it didn't, or something looked strange, or something looked
Mm-hmm.
weird. But I think that's also kind of, as your earlier point, when people saw the first law and didn't think about the other stages and kind of ignored it, people who kind of looked at the data first when the insurance company was probably just building out the data model for the first time and trying to figure out, how do we do this? How do we fit our system into this schema? That's come a long way as well, where now you're talking to multiple organizations across the country and matching to the penny with their fee schedule, and then having more detail, being able to slice by plan. So that's very encouraging. That's why we started this journey, to see things like this.
Yeah, and that adds to like kind of the contract negotiation strategy as well. Like maybe the client or the medical practice, they're contracted or they're credentialed with 3 out of the 5 plans available, but there's like 2 other plans that maybe they need to get on that they just, for whatever reason, they didn't get added to those 2 plans to open up their payer mix on it. Sometimes you can go in and show that like you have this many plans listed in the data. Competitor has these other plans listed on here. There might be some nuance in there to have a conversation on, like, if we're happy with the rates and we don't need to negotiate, maybe what we need to negotiate is getting on more plans or getting to the next level of plan to open our patient volumes.
Okay, that's really powerful. How has, with all of the hospitals buying up practices, opening up their own practices, PE, is there a way that this data can help practices stay independent? I think that's important for kind of democratizing healthcare, for communities. Is there a way that this can help them kind of not just stay alive, but thrive?
Yeah, I think there are some. I won't lie. There are some practices that need to be managed by somebody else. Like like let's not just assume everything is right. Like, people come to us for a reason,
Right.
for some help, and so there are people that left hospitals, left organizations because they wanted to be independent. Realize, oh, maybe somebody needs to tell me what to do, but being able to understand that. I've never really encountered an independent medical group that wasn't focused on patient care first. Like, this is, their after hours, like, how do we increase our rates? How do we stay afloat? Like, they want to take care of their patients first. We had one group that came to us. They were thinking about going down the private equity or getting merged into a big hospital system. And they came to us asking for kind of help cleaning them up, basically, helping with the revenue cycle, payer contracts, things like that. And we ended up helping them, and they just decided ultimately, hey, let's hold off on any mergers or getting absorbed right now because we're doing quite well. Wow. And so, they saw the benefit of renegotiating the contracts, collecting the revenue, things like that, to stay independent. Whereas, if they got absorbed or did something else, they'd have less control over their schedule or their patient care, their volumes that way. And this helps them do that.
What does the journey look like in practical terms? Let's say I've reached out to Eide, or I've purchased a price transparency solution, and I've seen that I could get across my high volume services and maybe some services that I don't do but should. I can get an X percent. I can get a 12% increase across the board, and then I go do that negotiation. Go have that negotiation. Have those conversations. How long from the opening up the door to have those conversations to having somebody in the medical practice go update your revenue cycle management system or whatever it may be with the updated rates, and then actually receiving that increase? Like, what does that journey look like in time and in challenges?
Yeah, I mean, it's a lot. Because a lot of times the smaller or the medical practices, they're not sure what their current rates are. So that's usually our first phase. Like, let's inventory what you're currently getting paid right now. So we, number one, know what you should be charging for it. We always inventory all their current contracts as they stand right now and kind of benchmark that against, national rates and what they're currently charging. A lot of times we'll find that there's been a change in their fee schedule that they just didn't log or didn't put in there. And they should actually be increasing their rates from day one. Like we can turn that over, after the first few weeks of doing
Wait,
the
Brian,
analysis.
the insurance company is not going to tell them that they're not
No,
charging as much as they should?
no. They
What?
put in their contracts that they will pay you the lesser of what you bill or their contracted rates.
Oh, wow.
So if you're billing too low, they're going to pay you too low for
Right.
it. They're not going to raise a flag on there.
Wow.
Anybody listening, like if you look at your remit advice, if your allowed amount is the same as your charge amount, you might want to take a look at that code and see if it needs to be increased. But usually our clients, we can find them some money by changing their rates, because there's some drug code or some office visit code that was changed last year or the year before, and based off of the methodology, they're getting an extra 50, $60 for it per visit, and that can add up to quite a lot.
This is important. Now we're getting into some details here. Like, can you double click into the allowed amount and the charge amount being the same, and why they would need to take a look at that? Can you talk to that?
Yeah, that's usually one of the first indicators. Like one of the first processes that we do is like, if we can get the allowed amount from their data, if they're logging into their EHR, we will check and just run that simple calculation, divide payments by charges. And if we're coming up 100%, then that's going to like ping a handful of our codes that we need to take a look at. If you're sophisticated enough, you can see which payers that is. You can say, oh, you need to go to payer one and get that fee schedule and see what that rate actually should be before we start negotiating.
I see.
And then change that rate, start collecting money now, and then maybe see if we need to renegotiate the rate. Like depending on the practice size, like you're looking at thousands to hundreds of thousands of dollars that we've had success with our clinics on doing, just because the maintenance of those fee schedules just is lagging. And I know you guys know, but the schedules can update quarterly on there. So there could be a quarterly change. A lot of clinics don't even update their fee schedules annually for those change.
Oh,
so
no.
They've
Leaving money on the table. Huh. I guess that goes back to your earlier statement. It's some of these things aren't being managed as closely as they should. I mean, this is the lifeblood of the business, being able to operate and deliver. You hope that the margin, and I know some of it is going to go towards better patient care and getting more providers. And I mean, this is important. This is really important for a medical practice to get this right.
Yeah, if you think of like medical practices, like they're not staffed a lot to do a lot of these things. Like if you're looking at, the 1 to 5 providers, the 5 to 10, like then you start getting into the more sophistication, educating people on there. Like, I hate to bring up the pandemic, but I don't think it's a podcast unless you bring up how things were during the
That's true. Actually,
but
yeah, this is the time.
But there was a lot of shift in personnel, like on revenue cycle teams. So somebody that was there for 20 years that had that internal knowledge of like knowing, like if we got paid 100%, let's ring the bell and like go back and check what we're charging, is might not be there anymore. So you have somebody there that maybe just got moved up from a different station in the office, that now they're in charge of the revenue cycle. They're keying in these things. And I remember my first 2 years or whatever doing revenue cycle, I'm like, oh great, we got 100%. Like that's a perfect score. Like in some people's mind, that's the right thing, but the way our system's set up, like you don't want to get a perfect score all the time, paid 100% for what you're charging. There should be a contractual adjustment on most everything that you're doing.
That's really helpful. That's really insightful. I love hearing these use cases. I love hearing not only, as I think about this and talk about this with a lot of people, everybody's talking about renegotiating their contract, and that's kind of scary and it's a lot of work. I was reading an article yesterday. It was the CEO. What's the hospital? I don't want to say the wrong hospital. It was just posted yesterday, a CEO talking about how they prepare for renegotiations. I mean, it sounds like they're preparing for war. It's like, get the PR team lined up, plan it out a year in advance. review everything and give the insurance company heads up. Maybe drop some things that you're doing with that insurance company to scare them a little bit, to know that you mean business. Like, it's like and it's like a year, 2 year process. Once they figure out that they might not renew the contract, get the PR firm to put up the billboards, shaming the carrier before the carrier does that. I've seen some
Right.
I've seen some scary. I saw one insurance company that put a video up. They were negotiating against a children's hospital and had B-roll of sick kids. It was like, these kids aren't going to get served anymore. I'm like, what? Who? This is inappropriate. Who let this out? Like, nobody reviewed this at the top, or did they just review it? And we're like, yeah. So it's very tone deaf, to say the
Yeah,
least.
it's a lot. Like back when I was practice administrator, like you could ask for an increase and get it. Like they treated medical practices, a lot differently.
Interesting.
Now we had one group that this was a few years ago before this was an option. Like we were renegotiating their contract, and the client had not negotiated in I think it was 16 years with the payer, and so they're on rates from 16 years ago, and like we're like, oh, slam dunk. And so we went to them. They're like, no, you need to give us a value proposition on why you deserve an increase over the past 16 years on it. So yeah, we had to do like kind of the same thing, like looking at the market, giving our value proposition is what we call it. Like,
You just
we
can't
have to,
respond with one word, inflation.
yeah, like we gave that information, like, yeah. And so you have to say,
Wow.
we're going to have this many more patients in the next 5 years. So it's not the same as it was, 10, 15 years. And understandably, like the people giving the increases, they have budget constraints. They have like things that they have to give into. So the more you can work with the provider rep and give them information, give them the better for it. So like any job in the world, the more work you do for other people, the more you're gonna succeed. Like if you make
Yeah,
things easier on the next person, um, yeah,
that makes sense. What I mean, so again, you're deep in this data. You're helping. I mean, all of these examples are amazing. You're helping so many organizations leveraging this information. If somebody's taking a look at this data, let's say a practice, um, they can, if they're lucky enough to have a negotiation with one payer that has a couple of files, and the files can actually be opened, and they have somebody to do all of the things to unravel it and flatten it and all of that. Let's say that in this pretend world that exists, this data should be uh, easier to get. It's way too complicated. But let's say somebody can get it. What are some nuances around the data? What are some things that you've learned actually looking at the data, from the place of service field to the billing class to the modifiers you mentioned, to kind of make sure you're looking at this stuff the right way and not misinterpreting things?
yeah. There's a handful of things that I've now just kind of put into my um, I guess you'd say processes for it. Like looking at it, like, I'm going to make sure have the correct NPI, like the group NPI, the correct tax ID number that I'm associating, the CPT codes, the modifiers. I have noticed like some payers don't necessarily post modifiers yet. Like I've seen like kind of on the state levels, they're not as compliant as like more of the national organizations, and it kind of speaks to like the maturity of their department publishing it. And so you
Right.
kind of have to make that decision, like if they're not publishing any modifiers, does this mean they're including everything in there? Does this include the professional and technical fee as part of like their rate and the minimum and maximum rate that they're pushing out there? You definitely want to look at um, the provider level, like nurse practitioner, or if it's a PA or it's a physician, like if that's available in there, just take that in consideration. Because if they're publishing the rates for a nurse practitioner, that's going to shift things down a little bit on the rate, because a lot of contracts will pay you a lower percentage of their max physician rate on there. Place of service has probably been the biggest one where I've seen nuances in how payers publish. Some of them have like a string of every single place of service code, and you have to like make sure that you're noticing if it's like a facility or a non-facility is included in there. Because independent practice, you work in your office and you probably also work in a hospital or an ASC, so you want to see what you're getting reimbursed for that based off of that place of service. Some of them just don't have a place of service. I noticed a payer, again, at the state level, it's just blank for their place of service. And so you just have to kind of make those assumptions and just disclose it, that this is what we're looking at it. Others just have one place of service for everything in there. So those are the big ones. And then also when you're comparing like a medical practice to a hospital or another institution, there's institutional rates and professional rates that are in there. You have to make sure that you're filtering down on the appropriate comparison. So it's more apples to apples, saying this is what the hospital is getting reimbursed for their professional rates. This is your comparison, not this way. Let's not skew it by including some of this other additional information on it. Usually when things aren't mapping up, it's because I left one of those things out on there. Like I didn't like do the right filter, or, if you're looking at a lot of organizations, if you're comparing a practice to a hospital can have an NPI or a tax ID for, in my opinion, like every door you walk into, like can have a different thing. Like the orthopedic group can have a different tax ID NPI combination. And so there's some searching that should happen, like to make sure you're comparing it. Like, if you're an orthopedic medical practice and you're just going to compare it to the hospital's group, make sure you're not grabbing their radiology reimbursement contract that, may have, orthopedic stuff in there, but it's not a direct comparison. You want to make sure you're doing some sleuthing, and that's where doing it on your own would be very difficult. Like, yes, you'd want to look at the NPI, look at like how things are rolled up to that organization, and select the right one, which is the biggest comparable for it.
That's really good advice. We've seen the same thing. It's not only just pulling organizational NPIs and then looking at the rates and even normalizing across the billing class. You talked about place of service, the modifiers, all of that. It's also what kind of NPI and tax ID combination are you pulling, and are those the appropriate taxonomies, apples to apples, because those orthopedic billing codes for that orthopedic tax IDs may be going to have a higher or different rate than if you're pulling the same billing codes associated with some other primary care practice under that kind of hospital umbrella. Am I kind of understanding that correctly?
Right. Yeah. Like I pulled a sample to kind of show like a prospective client not too long ago, and they're a larger clinic that wasn't aware that this kind of existed. And they had like a combination of 12 different NPI and tax ID codes just within their clinic because they have different locations across the state. And so I asked them, like, do all of these roll up into one fee schedule? And they're like, oh, we don't know. Like, so, they have to look into it and kind of get back to us on, which ones do we use? Like, because we just don't want to take the min and max of all of them, because that might not give us what we need in there. We want to be as specific as possible, and this helps us do that versus grab the tax ID for everything.
This is great. This is helping people get their house in order. Just even, and being brave enough and curious enough to jump in and say, hey, we want to look at this. And then you ask that question and they say, okay, well, we need to go figure this out. I hear birds whistling.
It might be my cuckoo
clock. It's like, where birds? We'll keep this in. A little spice in the podcast. There's random birds. That's a cool cuckoo clock. Well, I guess let's wrap it up with, this has been really helpful, Bryon, and encouraging. And I wanted you here, and I wanted you to talk about this because I want people to be encouraged. That there are experts. There are people that have all of the data. If somebody says, oh, nobody can get the data, that's not true. We can get it, and there are others that can get this data. It's all there. You can access it. And then there are experts like Bryon who have used this and compared it to contracts and lined it up perfectly and helped people. And kind of in some ways changed the trajectory of these medical practices, like the one you said that you mentioned that said, hey, we can just keep running independent. We don't have to be gobbled up by the Borg yet, because we've we've been able to increase our revenues and improve how we're operating. And so I guess I'll end with, Bryon, from your opinion, you've lived this and gone through this. What are some kind of highlights? What are some things that they can do to make this data better, from like policy enforcement of the existing schema to, hey, the contract kind of really looks like this, has these kinds of carve outs. The schema needs to be updated to capture this kind of concept.
Yeah, well, I think easier access, like making it more consistent. So getting it faster, like, right now, like I quarterly is probably the max that I can handle digesting it on there for when with things changing, um, and more of a standardized approach. Like right now, everybody's interpreting it their own way, so kind of a structured schema, like you said. I think you know that I know that I can do this filter and do it the same every time and not have to think, okay, now this is how this payer is interpreting the
Mm-hmm.
law. So I have to switch over my processes for this one. Okay, they're not having modifiers in there. So I need to do this carve out in my analysis of like, hey, they don't include modifiers in here, so we have to make assumptions. I think a standardized approach um, would make everybody happier. And my guess is the payers themselves would probably like a standardized approach. Like, tell us what to do and we'll do it.
Mm.
But right now, everybody's probably cobbled it together, stop paying attention to the next phases of what they should be doing. They're like, we spent all this time implementing it on this first phase. We're just going to stick to it because now we're just knee deep in how we did it. Um, yeah,
From your
and making it available.
from your mouth to CMS and HHS's ears. Um, I think that's really good feedback. I agree. I'll send them this clip, but I really I agree with you. I think getting now that we've in it, it's kind of a focus and expand approach as we've iterated through the law and the implementation of the law through the data. But now that we've seen kind of the total universe of what the insurance companies do and are posting, I think it's time to kind of focus that down into, to your point, okay, everybody do modifiers like this. Everybody do place of service like this. Um, have the contract at the organizational level. If you want to handle nuances of individual um, um, kind of rates at the individual provider levels based on those taxonomies, handle it this way. Um, those
Right.
kinds of things. And then I think also just enforcement of what people are doing today based on the rules today, even with the gray area. I think it's gotten great. United, which, I don't know if I was shocked when I found out or we discovered this or not, but United Healthcare has got some of the cleanest data out there as far as their completeness of their contracts, how the consistency of how they post, and then there's variation across United, Aetna, Cigna, Elevance, Anthem, and then Blues, which have nuances across the states and how they're doing things. But yeah, I think it's time to kind of consolidate everything we've learned into some more explicit rules, which will help everybody, to your point, interpret this in a consistent way. So I think
Right.
it's really good feedback.
Yeah, I don't think it's going anywhere.
Yeah.
So I think it's just something that just needs to be improved upon and implemented. Like ultimately, I think it'll improve patient care, because we're eliminating a hurdle. Like now, people know what it costs, what people are getting reimbursed. Like it used to be, providers just wanted to know, like, am I normal? Are these rates normal? Am I being treated fairly? And I think
Mm,
this kind of helps have those conversations, and hopefully it just gets better and better. And it, maybe it helps other insurance companies get into the market because they can know what the market is for it. Um, I mean, that could be the hope.
beautifully said. Beautifully said. Yeah. The more players, and I think with transparency we can get to something fair and equitable, and then to your point, we can let the free market do what it does, and kind of counterbalance this binopoly that has been the insurance carriers and large health systems that increase the cost of healthcare in perpetuity for, on one side, a publicly traded company that needs to show quarter over quarter profits for their shareholders. That's their fiduciary responsibility. And hospitals who also kind of operate at very high cost, and there needs to be some other pressure to lower the cost of healthcare. And I think we can start by, to your point, exposing it, which will help the patient. And that's really what this was for. It wasn't for this to get caught at the kind of large multi-billion organizational level to rebalance their revenues. This needs to make it down to the patients. And I know, working with people like yourself, Bryon, advocates and experts, putting this to work and sharing what can be done, I know we're going to get there. So we'll get there together.
All right. Sounds like a plan.
Sounds
or
like
a strategy.
That's right. Yeah, that's right. At least a strategy.
Yeah.
Well, thank you so much for joining us and talking about this and sharing your wealth of knowledge. And if people want to get a hold of you, I know you're on LinkedIn. Is there any way to get a hold of you in any other formal capacity?
LinkedIn is the best way to get a hold of me.
Good. Well, we'll see you out on the battlefield, and
right.
using this data and making things better.
Okay. Talk to you later.
All right. Cheers.